All right, well, good morning, everybody, and welcome to another edition with HRN Live. I'm my host, Alex Grichuhin, and of course we have Dr. Selsky, and of course we're all part of the HRN program itself. So, just a quick on an introductory. I'm Alex Grichuhin. I'm one of the respiratory therapists. Dr. Selsky is a doctor of cardiology, or a heart doctor. Okay. So if you have any questions, comments, anything like that, please go ahead and write your questions on the comment section of this live video, and we're happy to address any types of questions, concerns, or anything like that. We have a lot today as far as, sorry, I was just looking at some. As far as weight management, let me go over some of the topics for today, and if you haven't done so, please like and subscribe on our social media pages, especially on YouTube and Facebook.
Yeah, you don't want your friends missing out on this live stream.
Yeah, we have quite a bit of nice information and material to kind of introduce some of the different types of test questions that I even brought up on Microsoft Teams last night about omega-3 fatty acids, and it's and a lot of these other types of questions.
You were just full of just information last night.
Well, a part of the licensing that you have to always maintain is your continuing education credits. So for those that don't know, when you're a licensed clinician, whether you're a nurse, you're a doctor, or you're a therapist, or we have certain guidelines and rules, and one of the rules is continuing education. And my continuing education topics were based off of nutrition and cognitive speaking and development and things like that. So things that interest me, basically. Not saying all the other information is not really relevant, but anyways, not going that route.
I think everything interests you, Alex.
I know. From piloting to diving to everything. It's just nonstop. I know.
You make me seem boring.
Well, let's go ahead and jump into weight management. And if you have any specific questions, like I said, don't hesitate to ask a question if you need to. Has anybody ever heard of the refeeding syndrome? I'm going to read a little bit on this. Okay. So refeeding syndrome is a term used to describe the complex metabolic and clinical disturbances that occur after the reinstitution of nutrition to patients who are severely malnourished or starved. Now, I have a lot of patients that are very, very thin, and they tend to try to eat extremely healthy, which I think is always great, but there is a downside of it, and I want to kind of address this a little bit. Okay. Now, there's a very long word. It's hypophosphatemia, and that's basically where, you have impaired oxygen transport and delivery, hypoxemia, impaired cardiac function, impaired diaphragm contractility, respiratory failure, weakness, being lethargic, confusion, distortion, restlessness, seizures, coma, and of course death. And we also have hypokalemia and sodium retention, but basically, in a sense, does anybody know how much fluid? Let's just go over something very simple. How much water are you supposed to drink? Does anybody remember how much water? So fluid requirements, 50 to 60% of body weight consists of water. Fluid requirements are estimated at 1 milliliter per kilogram per day, or 20 to 40 milliliters per kilogram a day in adults. And for pediatric patients, the modified Holiday Sagar, it's SAGAR, 4-2-in-1 method is generally utilized. So how much water are we supposed to drink? We tend to say, 12 glasses of water per day, 8 to 12 glasses of water per day. But if you really want to know of how much water and fluid that you're supposed to be drinking, it's 20 to 40 milliliters, okay, not liters, milliliters per kilogram of your ideal body weight per day. So let's take you have somebody who is malnourished, somebody that doesn't have a lot of food, that doesn't eat a lot of food, or they eat incredibly healthy, and they're wondering why their oxygen doesn't look great, why their energy level isn't at their par level, par level. You know, they're not at a satisfactory level when it comes to energy. Meaning, the person who's malnourished, let's say, gets up and wants to walk, but they get so breathless. And a lot of people will try to contribute that to, okay, that's my lung disease. When a lot of times, especially according to the notes and lectures that I had that I went through, a lot of times is the energy intake. How many calories did you take in? I myself, and I can speak for myself, I myself have to consume at least 3,000 to 4,000 calories per day, or else I start losing a lot of weight. And if I don't consume that, you know, it's almost like a gas tank. You fill up a gas tank in a vehicle, and let's say you put in 5 gallons of gas, okay? And you spend all that gas driving from point A to point B, and you ran out of gas. So what happens? The vehicle doesn't work, right? It doesn't turn on, doesn't turn over, because there's no fuel in the system. When you consume, let's say, 1,000 calories, but you've burned 1,000 calories, after you have burned all those calories, what happens? Well, needless to say, your body will try not to want to move as much. You'll feel tired. You're feeling lazy, tired. You're feeling exhausted because you just depleted all the energy out of your body. And you're wondering why you get out of breath because you don't even have it's not nothing to do with your lungs per se. I'm not saying because you don't have lung disease. A lot of people contribute certain diseases to certain things that are happening to them. Like a lot of people when they exercise, they are like, oh, I'm out of breath. So that's obviously lung disease. That has nothing to do with me being out of shape or I am malnourished and I don't have a lot of energy. I mean, remember how much the brain consumes on oxygen? Do you remember that? Every breath you take. Everyone, right now, please do me a favor. If you don't know this, let's do this together really quick. Everybody, just take a deep breath. That one breath you just took, 30% of the oxygen just went to your brain. 20% was just consumed by your heart, on average. Okay? So let's say your brain, let's say you're going through a lot of stress. You have high anxiety. Will your brain consume the same amount as if it was resting, not anxious? No, of course not. It will consume more. Some people are out of breath just because the brain is consuming a heck of a lot of oxygen, and that oxygen is, of course, when something consumes oxygen, what is released? CO2. Remember, it's the CO2 that really causes the work of breathing. A good way of looking at how high your CO2 is, just a rough guess, is just looking at your heart rate. The higher the CO2, the higher the heart rate. So can you be out of breath because you're out of shape? Yes. Can you be out of breath because you're anxious, not doing anything? Of course. Can you be out of breath because you're malnourished? Yes. Can you be severely out of breath just because your muscles are weak? Of course. They might take 3 times the amount of energy to spend, taking as much calories as possible to make those muscles contract well. And those muscles need oxygen, a lot of nutrition. Does anybody have any questions on that so far?
So we do have one question.
I love it.
Dr. Selsky, did you have something that you wanted to add to it before I get?
Well, yeah, if you don't mind. It's very interesting because Home Rehab Network, we have 2 separate divisions, pulmonary and cardiac.
Right.
So the pulmonary, as everyone knows, we're dealing with COPD, bronchiectasis, pulmonary fibrosis, lung problems. And then the heart division, we're dealing with people primarily who had a heart attack, stent, bypass, valve problems. But interestingly, just hearing you talk, Alex, I know a lot of patients with COPD start to get malnourished or lose weight, or their BMI, which we'll talk about in a little bit, the BMI, body mass index number, is low. Well, on the cardiac side, we could almost draw a line down the middle here. That's very rare. Most of our patients are overweight or obese. It's very rare in my world, in the cardiac world, to be dealing with people that are underweight. Most people are overweight, so we're telling them lower your calories, lower your fat intake, lower your carb intake, You see what I'm saying? Our goal is to get people to lose weight. Your goal is to get some of the malnourished people to gain weight. And the tricky ones are people that have both.
Yeah, absolutely. Absolutely.
COPD and a heart problem. So they may be underweight from the COPD standpoint. And here I'm telling them to lower their fat intake. See what I'm saying? It creates a situation. But in reality, most of our patients are on the other end of your spectrum.
Yeah,
not malnourished.
And where would I find? Does anybody know where? And I'll address that question that came up. Does anybody know where I found this information? What are good resources I could use as a person that's independent at home, and I wanted to obtain some information that is good information? Where would I go to? Would I just go on Google? Should I just go on to WebMD, or should I just take the information from somebody on Facebook? No. Anything that you want to look into, I always love peer review. I love peer review. I love published papers, because these are things these are studied information, right? This is studied topics, and it's also brought to a review board. We can look at an IRB if you wanted to investigate a review board, but it's not necessarily just peer review. You have another clinician looking at it, seeing if there's anything, if there's anything contradictory to it, and looking at the pros and cons. And you have another clinician doing the same exact thing, and they compare the notes. So, needless to say, the information that you would read most likely is higher in probability, and of course, there's a specific word I'm trying to use here, a constant. So basically, where it's reproducible is what I'm trying to say. Okay. Let's go over that question. What was that question, John?
So the question was, sorry, I had to do some producer stuff. Excuse me. The question was, I'm about 80 pounds. So, what would be the best way for me to figure out my intake?
Well, saying that you're 80 pounds, it doesn't mean a lot. I'm sorry, but I would need to know what your height is, because if you're 80 pounds and you're 3'4", then I would say that would be okay, right? But if you're 80 pounds and you're 6'1", then of course you're very underweight. So I would like to know what the height is, because we look at height. So if you can, if you don't have to, but if you want to at least bring up, what your height is. Did that come up?
That's a great.
4'11".
That's a great.
What's that?
That's a great.
4'11".
That's a great point, Alex. The height is very important. That's why most clinicians, most doctors don't just use height or weight. They use a combination formula called the BMI. B like boy, M-I. So people have a hard time remembering the numbers. It's easy to capture your BMI. You can either calculate it, or you can go online on a BMI calculator and just put in your height, your weight, and it'll tell you your BMI number. And every time you go to a doctor, that's what they're using. So underweight is below 25 on the BMI. So 18, I'm sorry. I just said that wrong. Excuse me. Sorry.
No, I got you.
Underweight is below 18.5 on the BMI. Some people use 20, but under 18.5 is underweight. A normal or ideal body weight is 18.5 up to 25. And again, it's easier to think. 20 to 25 range is a normal, ideal BMI. Overweight is 25 to 30, and then obese is 30 or greater. So basically, under 20 is low, 20 to 25 is perfect, 25 to 30 is overweight, and 30 or above is obese, because that incorporates the height with the weight.
Gotcha.
So great point, though.
So to answer that question, so if you're 4'11", you're closer to about 105. So pounds is the ideal body weight version of that. If you go onto you could this time, I hate to say it, but you can go on Google this time, right? But if you go on Google and just type in BMI stands for Body Mass Index. And type in the information there and see the results. And compare the results with what is considered, overweight, underweight, and take a look at some of the information that they have with that. Somebody who's malnourished, can somebody malnourished be obese? Can somebody malnourished be obese? It's a simple question. It's not very complex. I'm not trying to be ambiguous here. But can somebody who is overweight be that is malnourished? Of course. Of course. Look, if I'm consuming, and I hate to say it, but if I'm consuming donuts and coffee every single day, all right, I'm not bringing in much protein, if any. I'm not doing a lot for my body. My body needs certain vitamins, certain types of nutrients to satisfy my body. But if I'm eating donuts only and pizza, which right now I'm salivating, but if I'm eating just that,
don't come at my diet like that.
If I'm just eating that, yeah, of course I'm being malnourished. Because why? The nourishment for my body, what my body needs, I have an excessive amount of sugars coming in me, but I don't have enough of the other nutrients that is vital. Okay? Does anybody recall, if you were an HRN, what are the 3 vitamins that you can't overdo? Meaning I can't abuse them. If I take too much of it, might cause an adverse effect. I'll give you one. Vitamin A. Does anybody recall that? All right, it's A, D, E, and K. If I take too much of it, it can. Now it will. It can, because it all depends on your body's metabolism and a lot of configuration with your body's basic chemistry. So can an overweight person be malnourished? Of course they can. Can somebody very thin be malnourished? Of course. That's usually what you see. But we just have to understand what the body needs versus what the body, wants. Yes, Dr. Selsky.
Along those same exact lines, Alex, years and years ago when National Geographic magazine was very popular, most people
I love that
looking
magazine. Oh, I love those.
It was great. But they frequently had pictures of these poor young kids that were extremely malnourished, and most of them looked like they had a great big belly. So everybody was always confused if they're malnourished or belly. It turns out if you're severely malnourished, your protein levels drop to such a low level that it causes fluid, not fat tissue, fluid to seep into your tissues. So people start to swell in their ankles and legs and swell in the abdomen or the belly. So it made them look like they were obese, but it was all fluid from being malnourished. So their weight actually could be up from fluid weight, and they had what's called ascites, which is extra fluid in the belly. So it made them look fat, but it wasn't fat tissue, it was fluid.
That is very
these
interesting.
These kids were profoundly malnourished. Profoundly. I do think our viewer that asked the question, what do you do when you're malnourished? I think it's very tough if somebody has heart disease and lung disease. You want to increase your caloric or calorie intake, but at the same time, you want to reduce your fat or cholesterol intake. So it's a catch-22. I think in situations like that, sometimes it's best to meet with a dietitian because that's such a tough situation.
Yeah, but I go straight to the dietitian. Mm-hmm.
Go for a formal consultation. You can do that online. Sometimes insurance will pay for it or cover it. And you don't necessarily need a lot of sessions, but go spend an hour with a dietitian on a consult. That might be really helpful.
Yeah. And communication with that, when you're with the dietitian or when you're with a doctor and you're not, let's say you have this problem, but you don't want to relay that problem because you're afraid of what the answer might be. I was actually reading upon this on my continue education things. my credits. And one thing it was stating is that a lot of people are afraid of results from their doctors. So if let's say they have chest pain periodically, but it's only happening like once a week, and they don't relay that with their doctor, then a doctor doesn't know what might be going on, because the doctor doesn't have an X-ray in front of their eyes. It's they have to, they really look at the information that they obtain from their patients. So when the doctor says, "Hey, what's been going on? How's your health? Have you had any problems lately?" And then you don't address something because you're afraid, all right, chest pain might be heart attack. I have something wrong with my heart. Waiting to the last minute is literally the worst thing that you could ever do for that. I know it sounds scary, especially when you're hearing things of heart disease, because if your heart's not working, you're closer to death. I would have to say, and at least that's what my mind frame would be. So let's look at real quick. Was there another question? I'm sorry, John. Was there another question on there? No. Okay. Well, let's look at carbohydrate requirements. All right. So carbohydrates are the primary fuel source for the body. It is recommended that approximately 45 to 65% of the total calories from carbohydrates are intaked. A minimum daily amount, so if you have your pens and paper available, I would write this down, guys. What is the minimum daily amount of carbohydrates? Carbohydrates, and there's ATP, adrenaline triphosphate, adenosine triphosphate, ATP. It's the powerhouse, basically, kind of like the mitochondria. The mitochondria inside of a cell. You have the mitochondria. It's what makes power. What makes energy, basically. So carbohydrates, the minimum daily amount of 100 to 150 grams a day in adults is necessary to provide adequate glucose to the brain. So I'm going to repeat that. 100 to 150 grams a day in adults is necessary to provide adequate glucose to the brain. If consumed in insufficient amounts, an accumulation of ketone bodies developed as a result of excessive fat and protein catabolism and acidosis occurs. It's a bad thing. Let's look at it that way. You don't want any type of acidosis. Anyways, protein requirements. Does anybody remember how much protein you're supposed to take in per day? Now, mind you, this is just general information. When you want specific information based off of your metabolic needs, you would go and talk to your doctor or a dietitian, but specifically first your doctor. All right, knowing what your protein needs are. But anyways, so in protein, because illness usually increases protein catabolism. Does anybody understand what catabolism is? Okay. Well, we understand what a cannibal is, right? Somebody that eats human meat, right?
Yes.
Okay. So I want you to look at it that way. The body's kind of eating itself a little bit. It's cannibalism. So if you don't take a lot of protein in your body, and let's say you're malnourished and you don't have enough protein in your body will try to take some from its muscles.
You said catabolism with a D?
Catabolism. It's Catabolism. Catabolism. And protein requirements. The recommended dietary allowance, RDA, is recommended dietary allowance of 0.8 grams per kilogram of body weight per day in adults, or 0.8 to 1.5 grams per kilogram a day in pediatrics is generally insufficient for critically ill patients. What does that mean? It sounds like a lot to know, right? Basically, if you have a certain disease, your body is, let's say your body's constantly fighting. You're immunocompromised. Your body's constantly fighting an infection. It might need to increase the caloric needs and protein needs, and that's why when you have an infection and you have, let's say a list that you were discharged from the hospital or your doctor's office, and they give you a list of things that I want you to eat and what to stay away from. Does anybody remember how much salt is too much salt?
I do not. Could you explain that to me, Alex?
Really?
Hi.
Come on, guys. We're HRN. You guys are supposed to be the Bentley. All right. Salt. Okay. So does anybody know the quantity of a teaspoon? I think you understand of a teaspoon, right? Okay. It's not a lot. Okay. 1 gram per, like it's 1.5 grams or less is good, is actually better, but 2 grams per day. Day, not per serving. 1 teaspoon of salt, that's it. Where do we obtain, what is salt used for in our body mostly? Well, it's used in a lot of different functions in our body, but one thing is acidity, meaning that salt, for you to digest things, you need salt, just not a lot of it. Okay, but too much salt will hurt you, of course, you know. But we usually obtain salt from foods, just eating foods. I'm not talking about fast food places. I'm talking about just if I pick up a banana, if I pick up some chicken, and I don't put a lot of ingredients on it, or no ingredients, I will still obtain salt from the meat I ingested.
Well, that's similar to what Michelle just said. She just commented, we have salt in all our food.
Exactly.
We don't need to add any salt.
Right. And that's one thing that I see a lot of people, when they add more salt, more sugar, they're trying to make it taste better. But if you limit the amount of salt, limit the amount of sugar, and maybe not even use any sugar, but let's say you limit the amount, your body will start enhancing itself of tasting those foods, making it more pleasant to you. So at first, let's say you start that new regimen, at first it probably won't, it'll taste kind of bland, you don't like it. But if you keep eating that same thing, or not having as much salt or much, sugars, then your body will start making your palate, your tongue a little bit more sensitive. And you can actually taste the foods a little bit more, I don't want to say acutely, but food will be more enjoyable because your body's now getting used to the low amount of salt, and now it's trying to make the food more tasty for you.
So it's interesting that you say that because when I was on a macro diet about a year or two ago, I noticed that foods really started to taste, like I could taste the salt in every food that I ate, and really just I was trying to limit it because it was overwhelming at certain points,
Yeah. Oh yeah, yeah. Well, I hear a lot of these people. What's that, Dr. Selsky?
I was just going to say, in the salt or sodium world, I totally agree that there's sodium and salt in most things, but some foods are much, much higher than others. So I think if a person is really working on a low salt diet, the worst ones would be processed meats like lunch meats, ham.
Yeah.
Oh my goodness, ham is filled with sodium. But even turkey and chicken and other deli meats have a lot of salt. Canned soups are filled with salt. If you go look at the labels,
Higher shelf life.
amazing.
Right.
So some of the soup makers make low salt. It'll say that on the front, like Progresso has one, where it says low sodium, low salt. But it doesn't taste the same. It's amazing the difference. Used to it, but it does taste different. Soda drinks, Coke products have a lot more salt than people would ever drink. Oh, and then here's the big one: frozen foods. They fill them with salt. So TV dinners, most of them, if you look at the sodium intake, it's huge.
And I think with the higher sodium intake, the reason why they add some sodium to it is for the higher shelf life expectancy. So
I feel like that could also be an American thing as well, because from what I've heard in other countries, they don't put salt and do all that.
You ever been into Italy?
Okay, fair. I didn't say that there was.
I had something. It was pork rinds or something, and it was.
That's gonna have a lot.
Oh my goodness.
Well, it's just pork in general has a lot of salt in it.
Yeah, but the way they cooked it, and this was in Key Biscayne, I believe, and it was incredibly salty. you know. And I was like, "Did you guys add a lot?" He says, "No, we don't add anything to it. It's the way we cook it." I said, "Really?" I said, "I feel like I'm tasting salt water." It's just, yeah.
Well, that's how I feel when I eat ham. I feel like I'm just might as well have just taken the whole salt shaker and just put it on my tongue.
All right. Does anybody know about the problem with when you wake? I'm not sure if any of you can agree with me on this, but some people when they wake up they get a little moody.
Huh.
I think everyone's raising their hand. Yeah, that's me. It's like, what is that? What is that? A lung disease? No, that's not a lung disease. I said, but when we wake up in the morning, sometimes our bodies go. And I was reading this whole thing about it, and it was mentioning that if you wake up and you're a little moody, a lot of times it's your electrolytes are a little off. And some people, when their electrolytes are off a bit or the nutrition's off, the first thing you want to do is eat something or have your breakfast before you talk to anybody. It's kind of like, don't talk to me unless I have my coffee, you know? And you go into this hunting type of mentality where you just raid the fridge. But afterwards, yeah, you're fine afterwards. I found this very common, especially in nursing homes. And in nursing homes, there were a lot of people that are very combative. Now, this wasn't directly related to that from everybody. But there was a lot of people that when they woke up, they were very, very moody and they're very combative. And a lot of times it's their nutrition. Maybe they didn't have their coffee yet, but most likely the nutrition. You know, they haven't had any food. You know, they slept all night. They haven't eaten a lot, or they didn't eat a lot the day before. You know, and that could actually cause, you know, mood swings in a sense. So it doesn't mean that there's anything wrong with you. Your body's just telling you it needs to eat, and it's getting very upset that it's not. So a lot of times our body, well, actually most of the time, our body communicates with us, you know, from all different levels. But let's go over, see if there's any questions.
Well, what I'm curious about is how, so Dr. Selsky, so regarding diet on like the heart, are there certain things that like we should be aware of, what certain foods can do to our cardiovascular system, I should say, just as a blanket.
Oh, yeah. Well, again, unlike underweight people, most people in the cardiac circles with, you know, a history of heart attacks and stents and bypass and all the difficult stuff we deal with, the majority of people are overweight. So in our circle, cholesterol kind of drives the majority of this. So fat intake, we haven't really talked too much about fat intake, but saturated versus unsaturated fats is the biggest topic of importance. So saturated is bad. Saturated comes in processed foods, by and large, donuts, cake, cookies, pies, you know, shortening, things with a lot of shortening.
Okay, again,
So,
you guys are just coming for my diet. Just coming at my diet.
Saturated fats are terrible for your heart. Terrible. So if there's one single thing to look for when you're in a grocery store, it's obviously harder to do when you're, you know, at a restaurant. They don't really most places don't put the breakdown of saturated and unsaturated. But when you're at a grocery store looking on labels, saturated fats are terrible for your heart, whereas there are healthy fats. So unsaturated fats are much, much better. So things like olive oil, avocado oil, eating avocados, those have good fats, not the saturated fats. So if I had to put in one plug, even when we were talking about carbohydrates, processed foods are generally bad. So the more something comes in a package with chemicals and preservatives, and I'm not saying you can't eat anything with no preservatives, but the more processed it is, usually the worse it is as far as carbohydrates or fats or any of those, you know, even the protein part. So if you're looking at carbs, there's nothing wrong with fresh fruits. So if you look at the Mediterranean diet, for example, it's based out of Europe in the Mediterranean region. It's a very healthy diet, and it has 6 or 7 or 8 servings of fruit per day. So it's a lot of carbs, but it's not potato chips, and it's not a donut. It's healthy fruits. Mm-hmm. So there is such thing as healthier, non-processed or more natural carbohydrates instead of processed ones. Same thing on the fat part. Eating a pizza, Alex's favorite food. With all the cheese on top, it's filled with fat. So go eat some whole grain bread and dip it in olive oil with a little pepper on it. That's a healthy thing, as opposed to eating the cheese that's going to have a lot of unhealthy fat. So there's always, again, not processed, healthy carbs, healthy fats are much better.
I just want to point out the fact that we are talking about this right before lunch. It's very upsetting to my stomach right now because I can't have lunch.
Well,
at least it's before lunch. If it was after lunch, you'd have to look at what you just ate and say, "Oh gosh, I didn't do that right."
Okay, fair. Touche.
One thing with my patients I can at least speak for is when they're starting a new workout routine that I set in place for that patient, and I tell that patient to weigh themselves every day. And let's say you take a 7-day period. We can look at a 5-day period, but let's look at a 7-day period, a full week. So let's say the person weighs 200 pounds. And they started this workout routine. They're working out for 25 minutes on a, let's say, treadmill and some heavy weights for weight training, okay? And the person weighs 200 pounds. The person is consuming the same amount of foods they did religiously when they first started. So the person weighs 200 pounds. Okay, they're still consuming the same amount they usually do. No alterations on food or diet yet. Okay, and the next day they're maybe like 199 pounds. And the next day after that, they're at 201. And the next day after that, they're dropping a little bit more weight. What do you think is happening? Is the patient staying the same? I know it's hard to say out of a week. What's the point? So my point on this is, what's the point of weighing, going onto a scale, weighing yourself and jotting it down on a note, like a notepad or on your calendar? When you're starting an exercise routine and you're staying with the same diet as you did when you first started, and you find yourself losing too much weight too fast, that's a problem. Okay? Yes, that's a big problem. Let's say you're starting your workout routine and you start increasing weight too fast. Is that another problem? That could be a problem. Based off of your metabolism, and that's why it's a really good idea today at the end of this, is go and take a look at your BMI, your body mass index, and see where you score at. And don't be discouraged of what you hear and see, because it's a general definition amongst like 100,000 people, if not more. It's not like, okay, it's going to lead to this, this, and this, and that will be you. When you're not sure about the results or outcomes, you always want to talk to a healthcare provider for it. But when I find a patient starting an exercise routine and I see that they're consuming let's say 1,000 calories, because they've always consumed that, and I see that person dropping weight too quickly, they're not consuming enough. Has nothing to do with their respiratory problem or their, all these other problems they have. They're not consuming enough. And that's going to lead to a very big problem, of course. Do you find, Dr. Selsky, do you find that it's beneficial to jot down when you're starting a new diet routine, when you have to relay information to your doctor? Do you think it's of course, I know it kind of goes without saying, but is it important for somebody to always take notes of their vitals every day, especially when they're trying to enhance or better themselves?
Alex, I think it depends a lot on the patient and what the goals are. So, we're all like snowflakes, everybody's different. So, I do think if you're starting on a new diet or starting on a new exercise program or both, I think a daily weight's a good idea. You have to realize, though, that the scales are not perfect. I've even weighed myself on my home scale first thing in the morning after urinating, no clothes on, and you get your weight and give it 3 or 4 minutes, step back on the same scale, and I get a different number. I'm like, oh, hey, I lost 2 more pounds. So, you have to take a grain of salt. I love that. We're talking about salt. Take it with a grain of salt. Not every scale is exactly correct. I do think it's better to look at the trend. If there's one group of cardiac patients, again, I don't want to branch on too much, cardiac patients where they really should be weighing themselves every day, that's the people with congestive heart failure. Because in those cases, if they're really starting to build up fluid in the lungs and fluid in the body, it's better to catch it when they've only gained 4 or 5 pounds in a matter of a few days, because that can be a sign that their congestive heart failure is flaring up. So we tell every patient with congestive heart failure to weigh themselves every day. But as far as your question on the exercise part, is it useful to tell your doctor? Well, I don't want to sound too out there, but between doctors being burnt out, they call it burnout. So many doctors now are just fed up with their electronic record system and typing on the computer and prior authorizations and insurance companies, that so many doctors now spend a few, and I'm sure a lot of patients have encountered this, a few minutes with the patient. And as the patient's asking a question, they're already listening to your heart and lungs. And a minute or two later, it's like, well, I had a question, and the doctor's starting to back out of the room already. I hate to say that. It's a common phenomenon. And it's sad that it's kind of come to that.
Is that more common now than it was before, you feel?
Dramatically. There's actually published research studies on that showing that that's a huge problem now. But unfortunately, you're there with a heart problem or a pulmonary problem, and the patient comes in with all this data written down on a piece of paper, my weights. Well, out of that 4-minute visit, you just used up 2 of your minutes. See what I'm saying? So yeah. I hate to say it, but a lot of doctors or these days, if the patient's malnourished and has questions about it, they'll say, oh, go see a dietitian or just try to eat more. And that's the advice. I mean, come on, seriously, it's a lot more complicated than that.
I remember that one patient, was it Williams? It was William on YouTube. I want to say it's a different name, but I remember on YouTube, this was several months ago. And
can you describe it more?
Yes. They were, gosh. They were talking, it was talking about, I wish I just, I should have, well, I'm sure I did write it down because I'm remembering parts of it. So, but there was a patient on YouTube talking about, heart disease, talking about problems they're having with their, that's what it was. All right. Sorry, as I digress. So the patient was saying that when you find a doctor that is not paying attention to you that much, is that a bad doctor versus a good doctor, and what's the difference? And, I think burnout, and this is just from my opinion, mind you can have a different opinion, okay? But a good and great doctor can also be burnt out.
Oh, for sure.
Okay, it doesn't mean
maybe no longer functioning as such a good doctor.
Right.
They had potential. They're smart. They're caring. They have compassion. But if they're not giving the patient the time they need, are they really functioning as a good doctor anymore?
Yeah.
Where it's a problem. It's a big problem. And one thing I got to throw out, talking about exercise and weight and daily. Again, I hate shifting from your malnourished folks to my patients that are overweight or obese. But in our world, everybody's trying to lose weight, because if you look at the statistics nationally in the United States, remember we talked about BMI of 30 or greater defines obesity. The statistics nationally, how many patients are obese? It's more than 40%. It's like 42% of adults in the United States are obese. So most of our folks, and people that fell into the trap of already having a heart attack and a stent or bypass surgery, they need to lose weight. And here's my important point. So many patients have a misconception that exercise alone will cause them to lose the weight they need. And I'm a huge fan of exercise. I think it's great for your whole body in so many ways. But if you look at the number of calories you burn with exercise, if one, again, it depends on the person's height and weight and how fast they're walking, but let's just say if you put a person on a treadmill or an elliptical machine and they do 30 minutes of good cardio, they might burn 300 or 400 or 500 calories from that workout, right? So let's say 300 or 400, maybe 500 calories from that workout. And a lot of the machines these days at the gyms will tell you, you put in your age and your weight, how many calories. But let's say 300 or 400 or 500. Well, a pound of fat in the body is 3,500 calories. So if a person works out doing 500 calorie workout per day for 7 days, that's 3,500. They might lose a pound in a week of working out. A pound.
That's great to know. That's good information.
So it's better to lose a pound than gain a pound if you're overweight.
Right.
But my bigger point is if somebody's 60, 70, 80 pounds overweight, it's going to take a long time to lose that kind of weight. So I had people who had terrible knees from arthritis. They said, Dr. Selsky, now that I've had my, I'm scheduled for my knee replacement next month, then I'll be able to lose this weight. And I'm like, you can lose that weight now. You have to go on a low-fat, healthy diet. Not processed carbs, low-fat, low-carbohydrate, as far as processed carbs. Diet plus some exercise, you'll lose a lot of weight. If you just keep eating the same you are and do that elliptical every day, you're not going to lose 70 pounds. It's not going to happen. So I think diet is the most critical part of losing the weight. Exercise helps a little.
So here's a question for both of you that would apply to both of you. How much do you hear patients talk to you about the cost of healthy eating and how expensive it is? So how often do you get not that excuse, but that reasoning as to why, it's just easier to have this piece of pizza because it's cheap food, it's cheaper, whereas you go to the grocery store and buying fresh kale can cost upwards of $7 a bag, so, or not a bag, but you get the point.
Well, I think you're totally correct, John, and that's been studied, that's been documented, and it's definitely a factor and definitely true. I think in general, patients don't advertise that. They don't want to say I can't afford it or use that as an excuse, but it is very real. Especially in low-income areas. If somebody's really struggling with, living on Social Security income, a box of macaroni and cheese might be $1. Fresh fruits and vegetables, especially if you got them organic. Oh my goodness! Even apples now. You buy a large apple at Wegmans, it's like $1.50 per apple. It's crazy with inflation. So no, you're totally correct. Healthy foods, and like I said, avocado oil and olive oil are the healthy fats. Try finding a bottle of olive oil for under $5. I mean, it's very expensive.
You almost have to wait for it to be on sale.
Well, did you hear about that? There's some cities doing. I know in other countries. I know in some other countries. I'm not sure in the United States. I would think there is, but there's a company, and we're not advertising this company. I'm just talking about this company. This company, what they do is they buy a plot of land, and they house the land. They basically make it into a big, huge greenhouse. And what you would do is you would pay, I think it was like $105 in pounds, because this was in another country. So let's just say $115, $120 per year. You would pay like this $120 per year, and all you would do is you would select which plants do you want to grow on this small plot of land, and every time it grows a fruit or vegetable, they just send it to you. And that's it. All you're doing is renting the land and the water. They provide every single thing else. So if you wanted a kale and you're in a city that you don't have the luxury of buying a land because let's say you're in an apartment or something, or in a house or a townhouse that doesn't really have a lot of land or anything, or the environment is not sufficient to develop crops, this company, what they would do is that you give them, you rent the land per year, and they will actually grow it for you. They grow the plants, and like if you had corn, if you had, let's say, 15 stalks of corn, it'll also give you information of how to make bread, how to make bread out of it and stuff like that. It's really interesting, and it was designed for people that want to live kind of organically in a sense, but live a little more healthier without having to spend a tremendous amount. And it actually is working really well from what I saw, or what I've seen so far, is instead of spending on average about, I think it was $700 to $800 just on fruits per year, and then it was $1,200 per year average consumption over a 6 months period for a lot of the other varieties of foods that are just organically grown in a sense, and you're only spending about $35 a month versus $300, $400, $500, $600 per month for your family. So there was a big cost reduction.
The latest thing that I think is great is hydroponic gardening. Have you heard of that? Hydroponic gardening?
I want to start a hydroponic garden so bad.
Hold on one second. Keep doing. Talk.
So
We've done that. We've had one for a couple of years. We do it last summer. We didn't, but I'll show you a picture. I don't know
you gotta zoom. Oh, almost there. Gotta back up a little bit. It's blurry.
Oh, there you go. We have one of those.
Yeah. That's what I did. It's called a Home Hydroponic System, EXO.
Yeah, I got a picture. We
Yeah.
have the same thing, and it has a pump in the bottom.
Yeah, it has a pump in the bottom, and it just constantly flows water in there. And
Yeah, ours too.
yeah, I wanted basil. There was peppermint, mint, kale, tomatoes, rosemary, and when I grow it to a certain mature level, I'll take it out and plant it, and that's what I'll do.
Oh, we don't plant it. We just keep it in that.
You just keep it in that?
It's particularly good for things like lettuce or leafy vegetables or spinach. It's really good for. The tomatoes get a little heavy as far as the weight pulling down, but cherry tomatoes are really good in that.
Yeah.
In fact, even cucumbers are good in that too.
Is it? I'm surprised that it worked so well, because I haven't had any flaws with it. It works incredibly well.
But the part people need to understand, there's no soil.
Yeah, there's no soil at all. It's just constant water flow, and you treat the water, with certain vitamins, and that's pretty much all you're doing.
The nutrients and fertilizers. So somebody who even lives in an apartment, if they have a balcony with some sun exposure, because the plants need some sun, you can put a hydroponic garden on your balcony. You don't have to have a plot of land necessarily. It's a great idea.
Oh, that's fantastic.
Michelle says she has one too.
She has one too?
Yeah.
How's that working for you, Michelle?
I'll let you know when she responds to that.
That's great.
So I think that what we've been talking about is really good, but we have two questions that I really want to get to.
Sure.
Bit of a change of topic, because we're running short on time.
Sure.
They're same first name, and they both came from Facebook, so be aware that these are two different Michelles.
Okay.
So, first Michelle from Facebook says, "Good morning. Tuesday morning, woke up with a cold-like symptoms. She went to the doctor and unfortunately tested positive for COVID. They gave her prednisone and
Doxycycline.
Thank you." And she wants to know: is there anything else that we could suggest, or that you could suggest that she do to help? So I'll throw that to either of you.
Dr. Selsky, I mean, besides the prednisone and doxycycline are pretty standard. As far as anything else, I mean, from my perspective with COVID, I would focus more on the respiratory side. I would check volumes with like an incentive spirometer and just double check to see if I'm at least half of 65 milliliters per kilogram body weight. So for most people that are like 5'5" and up, like I'm 6 foot tall, so I should be roughly around 5,000 on my max. So if I use my ideal body weight, not my BMI, but my ideal body weight, which is based off of height, and I'm 6 foot tall, 180 pounds, would be my ideal body weight. Convert that to kilograms, and that's 81.8. I'm just going to round up and say 82. 82 times 65 is 5,330. Okay? So I just need to be half of that. So I need to be above 2,500. Okay? That will give me my minimum quotient. Okay? It will give me my minimum volume that I need to sustain life, being able to do and function just like everybody else. So I would check volumes. If I see my volume, I feel that my chest is getting tighter. It could be some fibrotic tissues. It could be from infection, swelling, a lot of different complications. Anything like that I looked at it as a warning sign or possibly something that's getting worse, I'm definitely going to let my doctor know. Now, to help out with that, I can do something, because if my lungs are getting a little stiff, that means the muscles are having a hard time stretching out that lung parenchyma, the pink tissue. It's made out of elasticin. The pink tissue is made out of elasticin. So, did we lose Dr. Selsky? Oh,
Still there, Dr. Selsky?
So,
Yeah, I did get lost for a moment there.
Oh.
Probably just the Wi-Fi thing. But
Yeah,
if my chest is feeling really heavy and really tight, it's really hard to breathe, I would focus on respiratory muscle training, even some lung stretches. Okay, but mostly I would let it run its course and listen exactly to what my doctor provided me is the best thing I could do.
What about you, Dr. Selsky? You got any suggestions on the cardiac side of things to be aware of?
not from a heart standpoint. Again, we talked about COVID a little bit unless the person's real sick and going into the hospital or having chest pain or some sign of new cardiac symptoms, most of it's going to be respiratory, not cardiac. I guess I'm certainly not a COVID expert, but from my perspective, if the person is high risk, and there's certain criteria for that, then, and if it's caught early, most primary cares would at least consider the antivirals like Paxlovid to reduce the severity of the illness. But if you just saw your primary care doc, I would think they would have addressed that already. So like most viruses, most people will do well. Rest, support, getting enough sleep, drinking fluids, taking Tylenol or medications that can just help you get through the symptomatic part of it. And most people will get better. But, also highly contagious. So the last thing you want to do is give it to your friends or family members. You got to keep that in mind. But hope you do okay there, Michelle.
Yeah, likewise.
If I can add, for myself, when I had COVID about a year and a half ago, I did take Paxlovid, and a side effect of it was like a bad taste in your mouth or like a nickel taste.
Oh, I had the same.
Yeah.
I had the exact same.
I helped that with Jolly Ranchers and like hard candies and sucking on them.
Processed carbs.
Yes, but sorry, when I had COVID and it beats the nickel taste in my mouth.
You could have had an apple or a banana, not Jolly Ranchers.
I tried eating healthy. I tried those, but it didn't help. All right. Anyway, I
took Paxlovid too. I had terrible diarrhea from it, which is a fairly common side effect. So here you're already sick with COVID, and you have a metal taste in your mouth and you have diarrhea.
Yeah.
But you know what? It's better than getting COVID pneumonia and getting sick and going in the hospital on a ventilator. So
this is true.
It's a trade-off.
Yeah, I worked in Italian restaurants a lot when I was a kid. And when I was a bartender, I remember a lady ordering, and I'm not making fun of anybody, but I remember a lady ordering, it was a chicken Alfredo with 3 times the Alfredo sauce. And like extra cheese and everything on it, and just all that, which I think was probably close to 6,000 calories, I think. It was a lot. And she said, well, I'm going to go easy on myself. I'm going to have a Diet Coke. A Diet Coke.
Oh, right.
I said, but I didn't say anything. I just like, okay. That's all. I was like, all right. A Diet Coke with all that. What's the point?
Well, you can't say she didn't try, I guess.
Alfredo anything has to be the worst of all time.
Especially the next morning.
I'm serious, because it has cream in it plus the cheese. So even without extra cheese, oh my goodness, anything Alfredo, chicken Alfredo, shrimp Alfredo, bad.
Everyone's like on their bucket list to eat today. You're like,
yeah, I can't.
You know, that sounds pretty good actually. I won't overdo it. You know.
Well, I personally can't do Alfredo sauce. It tears me up. But so we have another question. This one, Alex, you'll have more of a say with.
Okay, sure.
But I want to get both of your perspectives on this. This is from the second Michelle that I was telling you about from Facebook. And she said, I have pulmonary hypertension, and my doctor said that there is no treatment for, as she puts it, and this is in quotes, for my kind. Has anyone heard of this before?
No.
Yeah.
Of course not.
That's why I wanted to throw it to you.
Look, I'm not trying to be a downsayer or something of that nature, but no matter what disease you have, there is always some type of resolution as far as what you can do to help with that, you know, your current circumstances. Pulmonary hypertension, do we understand what pulmonary hypertension is? So you're looking at your pulmonary arteries. You're looking at, you know, high pressures in your pulmonary arteries. There's a condition called cardiomegalia. And that's usually due to, you know, with a high pressure and, you know, abnormal high pressure for a chronic condition. Let's say somebody has high blood pressure and they kept high blood pressure at, you know, at a very high level, you know, a very high pressure for a long period of time. If you take a balloon and you inflate it a little bit and you leave it inflated and you deflate it, it'll probably almost return back to its original shape. Okay, not as much, but if I took a lot of pressure and I put a lot of pressure into that balloon and I didn't let it pop, but I maxed it out and kept it inflated for, let's say, a few days, not months, just a few days, maybe even just a day, and I deflate it, obviously it's very loose and very, you know, it almost looks like it's tattered and everything. It doesn't return back to its original shape. Okay, so what happens inside the heart when you have too high of a pressure? It could lead to a condition called cardiomegalia, where you have an enlargement of the heart, right? With pulmonary hypertension, and I can't speak too far into it because I'm not a cardiologist, you know, but with pulmonary hypertension, if you have too high of a pressure in those pulmonary arteries, you're going to get the body's going to try to compensate. And how it's going to compensate is sometimes it creates where your arteries stiffen up, arterial stenosis. It can stiffen it up, it can make it more fibrotic, and then it requires higher pressure for it to function. You know, there's a lot of, but as far as resolutions to it, what can I do to help that? Well, what is the problem? Too high of a pressure. Let's look at fluid overload. Let's look at this. Let's look at lung disease. You know, and try to dissect but my point I'm trying to make is that there is always a way that you can improve yourself. Even if you're alive, I always say if somebody's alive, there's a reason. You know, I mean, there's always a chance to fight something that you might think, or maybe your doctor may think that is not possible to solve. And I'm not saying cure it, but helping yourself. If I'm weak, I lift weights to make myself stronger. If I'm overweight, I diet better, I exercise better. You know, if I have lung disease, I work on my lungs. If I have anxiety problems, I work on my anxieties and fears. There's always some type of resolution. It might not be 100% perfect, but it will be some type of resolution that would make it easier to live day in day with a certain complication that you may have. That's the best I can say with that.
Thank you, Alex. Dr. Selsky, do you have anything to add?
Yeah, let me throw out a few things. Pulmonary hypertension, as Alex just said, is an elevated pressure in the lung arteries. But there are a number of different subgroups or types of pulmonary hypertension. It's a very complicated subject. We typically make the diagnosis of pulmonary hypertension on an echocardiogram. That's the initial way. Echo is the sonogram, putting a jelly on the chest and taking the pictures like a mother with a baby. And that can estimate the pulmonary pressure in the lung arteries. It's a good estimate. And like anything, you can have a mild degree, moderate, or severe degree. But it's not just the degree of it. There are different causes and types of pulmonary hypertension. And most primary care physicians know little or nothing about pulmonary hypertension. And believe it or not, the average cardiologist has a very limited understanding of pulmonary hypertension. So if it looks like it's a fairly severe case, I mean, the echo's done and the numbers are really high, pressure in the lung arteries is really high, usually the next most appropriate step is to see a pulmonary hypertension specialist. There are cardiologists who only do work with pulmonary hypertension. So an average cardiology office doesn't have one, an average hospital in the United States may not have one. But if you look at bigger cardiac centers, especially universities, you'll usually find one or two or three pulmonary hypertension specialists. And frequently what they will then do, if it looks severe, is put in a catheter to measure the pressures on the right side of the heart and in the lung arteries. This is not a catheterization where they're injecting dye, taking pictures and blockages and stents. It's strictly to measure the pressures. So they can go in the neck or in the groin. It only takes about 15 minutes and you go home. But that can help guide which group the person's in with pulmonary hypertension. And I think what Michelle ran into, again, I don't know your case, Michelle, is that some of the subgroups are treatable specifically with medications that lower the pressure in the lung arteries. So some of the patients with severe pulmonary hypertension can go on a fancy drug, and some of them are crazy, a couple $1,000s a month. Some of them are intravenous through a pump, some are pill form, but the fancier drugs for pulmonary hypertension are usually under the guidance of a pulmonary hypertension specialist after having that catheterization done. So yeah, I would have to guess that in your case, Michelle, they put you into a type of group of pulmonary hypertension where it's not treatable with one of those medicines. So I agree with Alex, exercise can help, working on it can help, but you may not be treatable with one of the medicines. A big difference. But I'd make sure that you're seeing a PAH or pulmonary artery hypertension specialist. That'd be the first step.
Or even, heck, getting into pulmonary rehab like HRN. Right, Alex?
Yeah, but specifically what Dr. Selsky said.
Yeah, I think that can help the stamina and walking capacity, but may not correct the underlying condition. So I think if it's looking like a severe case of pulmonary hypertension, I'd at least get an opinion, even if it's inconvenient and you have to drive further and go through some other bigger testing, at least get an opinion from a pulmonary hypertension specialist. That's important.
Well, thank you so much, Dr. Selsky. So that's all we have time for today. We're running low on time. Do you guys have any final thoughts that you would like to share?
No.
About either our main topic or about either of those questions? Dr. Selsky, you got anything?
Go eat a healthy lunch.
Yeah.
Have a salad light on the dressing. All right, everybody. Well, thank you so much.
Thank you very much, everybody.
Have a great weekend, and we'll see you.
Don't forget to like and subscribe, please.
Right. Don't forget to
We're coming out with some really good information that it would be very nice to have it on hand in your back pocket. So, but you got to participate and you got to attend to see it, or at least view this afterwards.
Absolutely. Absolutely.
Pass the word.
That's right.
And like, share, and subscribe so that way your friends don't miss out, because you never know. Somebody that you follow might need this information just as much as you do.
I always know somebody, not because I'm a respiratory therapist, but I always know somebody who has lung disease. I'm sure that other patient knows that somebody has breathing complications too. So all the little information could actually help them.
The other thing too is if you guys, the viewers watching, have some suggestion on what topic you'd really like to see discussed, put it in on your comments section.
Yeah.
We can at least consider it.
Right.
Absolutely.
Absolutely that, or you can message us on Facebook.
And if you want us to show you a demonstration on something, like maybe, all right, when you're doing chest compressions, I'm going to throw this question. I'll answer it the next time, okay? I want you guys to see if you can look this up and what your answers would be. When you're doing chest compressions to save somebody's life, you have to go in about 2 inches. What is the normal cardiac output for chest compressions on average? That's all I'm going to leave you with. See you guys.
Actually, we could talk about CPR during some other session. That's not a bad idea.
I would love that. Yeah, I would love that.
All right, thank you, everybody.
See you guys.
All right.